Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with the previous lectures in neurology, this is one of the lecture which I'll be trying to make it as simple as possible, different terminology used during eyeball movement, what are the different eye muscles, how they act, etc. It will be animated videos which I've collected from YouTube, and I am very, very thankful to the person who has uploaded that video. I'm utilizing for education purpose only. So we'll be talking on those particular terminology and we'll be showing you different videos. So extraocular muscles are the muscles which will move the eyeball. So there are 4 recti and 2 oblique muscles. Superior rectus, inferior rectus, medial rectus, lateral rectus. And we have got 2 obliques, that is superior oblique, inferior oblique. And they move the eyeball in different directions. We'll be dealing with all those. So extraocular muscle, what are those muscles, what are the actions, and what are the different terminology which are being utilized to mention the action of those muscles. So we'll be dealing with that particular and we'll be showing you the videos also. Now you can see here, if you cover one eye and if you look at the movement of one eye, that is called monocular movements, movement of one eyeball. And when you remove this and you see the movements, that will be binocular and we call conjugated movements. First I'll be talking of a monocular movements. Say a medial rectus of this eye. This eye is right eye of a person. So when it moves medially, medial rectus is working. So medial rectus will move medially, we call adduction. And as it is towards medial, it is also called medial movement. Or we use a word inward, nasal. When lateral rectus is working, we use the word abduction or temporal movement or lateral movement or outward movement. So there are 4 words: temporal, abduction, outwards and lateral. While medial rectus will be inward, adduction, nasal and medial. While downward movement is also called inferior or depression, or you can call downward, introduction and depression. While upward movement or elevation or superior or superduction. These are the different terms which are being utilized. You can use any one of them, those. Along with this upward, downward, adduction and abduction, there is a rotation of the eyeball. That is called extorsion and intorsion. Meaning of intorsion means eyeball is rotated towards the medial side. And when eyeball is rotated outwards, it is called extorsion. The another word which is being utilized for that is excycloversion and encycloversion. So these are the terms. Now if we go through the movement of medial rectus and lateral rectus, medial rectus is pure adduction, lateral rectus is pure abduction, but superior rectus will have elevation plus adduction, while inferior rectus will be downwards and adduction. While inferior oblique will have elevation, abduction, and extorsion. So these three movements will be there by inferior oblique. While superior oblique will have downward movement, intorsion, and abduction. So there will be three movements of superior oblique, as well as superior rectus will also take part in intorsion, and inferior rectus will take part in extorsion. So putting together, adduction will be done by superior rectus, inferior rectus, and medial rectus, while lateral movement, or we call abduction movement, will be done by mainly by lateral rectus and partly by inferior oblique and superior oblique. Elevation will be done by superior rectus as well as inferior oblique, while downward movement will be done by superior oblique and inferior rectus. Extorsion will be done by inferior oblique and inferior rectus, while intorsion will be done by superior oblique and superior rectus. So these are the permutation combination of different eyeball movement and terminology which are being utilized. And we have mentioned the action of muscles. Now to understand that action of muscles, we'll be showing you some of the slides. Now when you remove this particular cover and you ask the person to look medially, laterally, upward, downwards, and then we combine the angles, that is upward and outwards, downwards and outwards, upward and medially, downwards and medially. There are a group of muscles which will be working together of right eye as well as left eye. And the terminology utilized is same: abduction, adduction, intorsion, extorsion. Then there is a word utilized is divergence and convergence. Means when the two eyeball, medial rectus, both medial rectus are working, we call convergence, and when they go away, we call divergence. Also, the word utilized is excycloversion and encyclovergence. And also, you use a word during rotation, version. There is one another word utilized is dextro and levo. Dextro means moving to the right side, levo means moving towards the left side. So, dextroversion, levoversion, and excyclo and encycloversion. These are the some of the superior, superduction, infroduction, superversion, infroversion. These are the some of the terms which are being commonly utilized. And you can combine excyclotorsion and entorsion, encyclotorsion, dextrocyclo and levocyclo. Now, we'll be going through this particular video. Just pay attention. And these are some of the terminology which will be utilized.
Hi, this short video is to introduce terminology of eye movements.
Now this is a video for all different terminology.
Versions and vergences. First, we will consider eye movements of a single eye alone, or ductions. If we face a patient with eyes pointing straight ahead, this is called the primary position.
This is normal position. When you cover the eye, now you are looking at the eyeball movement of one eye.
Movement of the cornea away from the midline
This is abduction.
abduction. Movement towards the midline is
This is adduction.
Movement upwards is superduction,
Superduction.
or elevation, and downwards is
introduction
infraduction or depression.
and
Rotation of
rotation.
the upper cornea towards the midline is incyclotorsion
Intorsion,
or intorsion, and rotation away is
extorsion.
excyclotorsion or extorsion.
And
Next,
now you
we
are
have
looking at the
conjugate
two eye
eye
together.
movements.
This is called binocular.
These gaze movements are termed versions.
The word utilized is version,
Gaze to the right.
versions.
The right eye is abducted and the left eye is adducted. Lever version is gaze to the left. The right
This
eye
is
is now
towards the right
adducted
side,
and the left eye abducted.
dextro, left side,
Upgaze and
levo.
downgaze are supraversion
Superdux.
and infraversion, although the terms upgaze and downgaze are also used. Also, there is dextrocycloversion where the upper corneas move to the right, and levocycloversion where they move to the left. Finally, we come to vergences. Here we have convergence,
This is
where
convergence.
both eyes are adducted, and divergence, where both eyes
Divergence
abduct back to
means
the primary position.
going away.
There is also encyclovergence and excyclovergence. So isolated movements of a single eye are described as ductions. Conjugate gaze movements of both eyes are versions. Vergence movements are equal and opposite movements of both eyes. Both version and
So
vergence
duction,
movements can be
version,
described as
and
combinations
vergence.
of ductions of the two individual eyes. To criticize
Now in this particular video, we'll be showing you all different muscles, how they act and how they work.
Functions of the 6 striated extraocular muscles responsible for positioning the eyeball: inferior rectus, lateral rectus, inferior oblique, superior rectus, medial rectus, and superior oblique. Each of these muscles receives motor innervation, general somatic efferent, from one of the following 3 cranial nerves: oculomotor nerve, or cranial nerve 3, trochlear nerve, or cranial nerve 4, or abducens nerve, or cranial nerve 6. A convenient way to remember this pattern of innervation is provided by the formula LR6SO4R3. That is, lateral rectus muscle is innervated by cranial nerve 6, superior oblique muscle is innervated by cranial nerve 4, and the remaining muscles are all innervated by cranial nerve 3. Before discussing specifics of eye movements, we need to understand the relative position of the eyeball within the bony orbit of the skull. When the eye is in its primary position, looking straight ahead, the visual axis, represented by a line from front
This is
to
straight
back
axis
through
of
the
the
center
eyeball.
of the eye, is parallel to the sagittal axis of the body. In this position, the eye deviates approximately 23 degrees nasally from the long axis of the bony orbit. In other words, in its primary position, the eye is significantly adducted. This will become important
So
when we start
relative
assessing individual muscle
adduction of the
movements in
eyeball
just a few
is there
moments,
in a
because
normal
all 4 of the
position.
rectus extraocular muscles are aligned with the long axis of the bony orbit, and, as we will see, relative amounts of adduction or abduction of the eyeball can alter some of their functions. We're almost ready to start assigning specific movements to the individual extraocular muscles. But first, there is one final relationship to establish that will help us to visualize muscle functions. The distal insertions of
This
all
is
4 of the
horizontal
rectus
axis.
muscles are anterior to the horizontal axis of the eyeball.
So
In contrast, the 2 oblique muscles have distal
2 oblique
insertions
muscles are
posterior
posterior
to
to
the
the
same axis.
horizontal axis, while
Understanding
all
these
other
insertions
muscles
will
are
greatly
anterior
help
to
in
the
making
axis.
sense of the muscle's functions. Now let us consider the 6 basic movements that the eyeball is capable of: elevation, or
This is
looking
elevation,
up;
looking
depression,
up,
or looking
down,
down;
depression,
adduction, looking in;
medially,
abduction, or
laterally,
looking out; intorsion, rolling the top of the eye medially towards the nose; and extorsion, rolling the
moving
top
the
of the
eye
eye laterally
laterally.
away from the nose. Of course, these movements can and do occur
Simultaneously,
in
you can
various
see the
combinations, some of which you
eyeball
will
movement here.
specifically assess during a routine examination of eye movements. For example, asking the patient to look up and out or down and in. The first 4 of the basic eye movements are relatively intuitive and easy to understand. The last 2, intorsion and extorsion, are a little bit trickier and may or may not be assessed in a basic eye examination. Nevertheless, it's important to understand what these terms mean and why they are necessary for proper eye positioning. The rotational movements of intorsion and extorsion are necessary to keep a viewed object stable and positioned on the appropriate part of the retina as the head is tilted from side to side. To illustrate, imagine standing upright and looking at an arrow that is pointing superiorly. Now tilt your head 45 degrees to the right. Does the arrow move with your head and now point at a 45-degree angle? Hopefully not. Because of intorsion and extorsion, the arrow should still appear to be pointing superiorly. In this case, the right eye has been intorted and the left eye has been equivalently extorted, so that the image falls on the same part of the retina as before the head tilt. Obviously, our eyes have a limited range of intorsion-extorsion. They cannot spin completely around within the orbit. And if we were to stand on our head, the arrow would appear to change direction and appear to point inferiorly. Now let's look at the movements produced by each one of the extraocular muscles. We'll start with the medial and lateral rectus muscles, since they are each responsible for producing a single, straightforward eye movement. Contraction of medial rectus causes
Medial rectus will
adduction
be
of the
pure
eye.
adductor.
Medial rectus is the primary adductor, though other extraocular muscles can assist in this movement.
Two muscles will
Contraction
be
of lateral
helping.
rectus causes abduction of the eye.
Abduction is
Lateral
purely
rectus
by
is the
lateral
primary
rectus,
abductor,
helped by,
though again, other extraocular muscles can assist
we
in
call
this movement.
obliques, two obliques. They will
The
also do
remaining four
abduction.
extraocular muscles are a little bit more complex, since they are capable of producing multiple eye movements, and their primary function changes depending upon the relative position of the eye within the orbit. The primary result of contraction of superior rectus is elevation of the eye. However, superior rectus is
will
most
be
effective
pure
at
elevator.
elevating the abducted eye. With increasing
In
adduction
abducted
of the
eye.
eye, superior rectus loses the mechanical advantage necessary for producing elevation, such that the fully adducted eye can be elevated only by the action of the inferior oblique muscle. In addition to its primary function, as an elevator of the eye, superior rectus also produces limited adduction and intorsion of the eye. The primary result of contraction of inferior rectus is depression of the eye. However, as is the case with superior rectus, the inferior rectus is
will
most
also do
effective at depressing
adduction
the
as well
abducted
as
eye, and loses the mechanical advantage
intorsion.
necessary for depression as the eye is progressively adducted. The fully adducted eye can be depressed only by the superior oblique muscle. In addition to its primary function as a depressor of the eye, inferior rectus also produces adduction and extorsion of the eye.
extorsion.
The primary result of contraction of inferior oblique is extorsion of the eye. As mentioned earlier, inferior oblique also assists in elevation of the eye and is the only effective elevator of the fully adducted eye. Inferior oblique also contributes to abduction of the eye. Finally, let's consider the most misunderstood of the extraocular muscles. The primary result of contraction of superior oblique is intorsion of the eye. Superior oblique also assists with depression of the eye and is the only effective
abduction.
depressor of the fully adducted eye. Superior oblique also contributes to abduction of the eye. Superior oblique is often referred to as the down and out muscle because, if acting in isolation, that is, with all or most of the other muscles inactive, such as occurs with third nerve palsy, or a quote, blown third nerve,
So this
it
will
does
be
put
very
the eye in the
typical.
down and out
When
position.
all the extraocular muscle of third cranial
However,
nerve is
as we will see, the
affected,
function of superior
superior
oblique
oblique
is
will be
not
powerful
tested by
and it
having
will
the
move
patient
the
look in
eyeball
the
down and out.
direction, but rather in the down and in direction. This is because the coordinated function of other muscles, specifically lateral rectus and inferior rectus, can put the eye in the down and out position, but only superior oblique is able to depress the fully adducted eye, that is, to put the eye in the down and in position. This discrepancy between the pure, isolated function of superior oblique and the clinical test of superior oblique function often causes confusion for students and clinicians alike. Now we're ready to understand the basic eye movement exam that tests the function of each extraocular muscle by having the patient sequentially look in each of 6 cardinal directions, also referred to as the 6 cardinal fields of gaze. These are in, up and in, down and in, out, up and out, and finally down and out. The basic exam involves having the patient focus on an object that is positioned 18 to 24 inches in front of their face as you move the object through a large H shape to encompass the 6 cardinal fields of gaze. The eyes can be examined individually or together. In our example, both eyes will be tested at the same time. Begin by allowing the patient to focus on the object with both eyes in the primary position, that is, looking straight ahead, neither elevated nor
This is
depressed.
primary position.
Slowly move the object to the patient's left until you reach the limit of his field
So
of view.
here the left eye,
Here, the
lateral
patient's
rectus
left
is
eye should be
working,
fully
right eye, medial
abducted,
rectus
and
is
the
working.
right eye should be fully adducted. This position tests the function of the left lateral rectus muscle and the right medial rectus muscle. Now move the object directly superiorly. This position tests the patient's left superior rectus muscle, up and out, and the right inferior oblique muscle, up and in. Continue by moving the object directly inferiorly to test the patient's left inferior rectus,
This will be inferior
down and
rectus
out,
and
and
opposite
the
eye,
right
superior oblique.
oblique muscle, down and in. Now return the object to the left horizontal position and slowly move it to an equivalent position on the right side. Here you can examine the function of the patient's right lateral rectus muscle,
And
abduction, and the left medial rectus muscle, adduction. Again, raise the object directly superiorly to test the right superior rectus muscle, up and out, and the left inferior oblique muscle, up and in. Move the object directly inferiorly to complete the exam by testing the right inferior rectus, down and out, and the left superior oblique muscle, down and in. You have now tested the 6 cardinal fields of gaze for each eye. There are other things that can be assessed with this basic eye exam, including smooth pursuit and the presence or absence of nystagmus. However, these are beyond the scope of this video. While this exam involves direct assessment of individual muscle movements, it is also an efficient functional test for the 3 cranial nerves that innervate the extraocular muscles. And in fact, disturbed eye movements result more often than not from central or peripheral nerve disorders, rather than from mechanical causes, such as muscle entrapment or trauma. Let's briefly go over what to expect with complete disruption of these cranial nerves.
now
For the
this
sake
is
of
showing you the
simplicity,
damage
we will
to the
assume
different
damage to the
cranial nerves,
brainstem motor
3rd, 4th and
nucleus of
6th.
each nerve, rather than a more distal lesion, is the cause of the deficit. Complete disruption of oculomotor nerve function, or third nerve palsy, results in paralysis of 4 extraocular muscles: superior rectus, inferior rectus, medial rectus, and inferior oblique. Patients with this disorder present with
The
the
eyeball will be
ipsilateral eye
pointing
stuck
down and
in the
out.
down and out position due to the fact that tonic activity of the intact lateral rectus muscle fully abducts the eye because it is no longer opposed by the medial rectus muscle. Further, the eye is depressed because the action of
And
superior
superior oblique
oblique
will
is no
move the
longer
eyeball
opposed
downwards.
by the elevation normally provided to the abducted eye by the superior rectus muscle. Because lateral rectus and superior oblique are the only remaining functional muscles, the eye is unable to move from this position. Complete disruption of the trochlear nerve function, or 4th nerve palsy, results in paralysis of the contralateral superior oblique muscle. The trochlear nerve is the only motor cranial nerve that decussates, or crosses to the other side. Patients with this disorder are
The 4th
unable to
cranial nerve is
depress the
supplying
affected
opposite
eye
eye.
when it is adducted, or in the primary position, due to the fact that the intact inferior rectus loses the ability to depress the eye as it is increasingly adducted. In addition, these patients are unable efficiently to intort the affected eye. Both of these lost functions can result in, quote, double vision. Many patients unconsciously compensate by tucking the chin, which eliminates the need to depress the
And
affected
person will
eye,
tilt
and
the head
tilting the
to
head
opposite
away
side.
from the affected eye, which eliminates the need to intort the affected eye. An eye movement exam of patients with trochlear nerve palsy reveals an inability to put the affected eye in the down and in position. Finally, complete disruption of abducens nerve function, or 6th nerve palsy, causes paralysis of the ipsilateral lateral rectus muscle and an inability to fully abduct the affected eye. These patients typically experience double vision except during near vision when both eyes are directed inward. Eye movement exam reveals an inability to abduct the affected eye beyond the primary position. Some of these patients compensate by turning their head toward the injured side, which allows them to adduct the affected eye and pair it with the normal eye, which will be abducted to a corresponding degree.
Hi guys, it's Mo here. Today I bring to you a neuroanatomy video designed to make eye movements and extraocular muscles easier to understand. This video will cover the basics, including an introduction to eye movements, the anatomy of the orbit, and the main muscles you need to know about. This is part 1 of a 3-part video series. In the second video, we will be introducing a novel method to help make the actions of the muscles easier to understand. In the third video, we will look at cranial nerve palsies to put this into a clinical context. Let's begin by talking about those basic eye movements. In the anatomical position, both eyes look straight ahead. This is
normal
the primary
position.
position of gaze. In elevation, the pupil
This is
moves
elevation.
upwards. In depression,
This is
the
depression
pupil moves downwards. In
or downward.
adduction,
This
the
is
pupil
adduction.
moves towards the nose.
We also call
Remember this as
convergence.
the pupil being added to the nose.
When you look at both the eye
In
together.
abduction, the
This is
pupil
abduction, or
moves
we
away
call
from the nose.
divergence.
You can remember this as the pupil
When both
being
eyes are moving away.
abducted or taken away. Intorsion or
This is
internal
internal rotation
is
or
the
intorsion.
rotational movement of the eyeball towards the nose.
And
Extorsion or
external rotation we call extortion.
is the rotation of the eyeball away from the nose. To understand how the muscles around the eye work, we need to understand the anatomy of the surrounding area. This is a horizontal cross-section through the head, showing the eyes from above. Here you can see the orbit, the triangular space where the eyeball and its extraocular muscles live. Note that the two medial walls are parallel to each other, but the lateral walls are at a 45-degree angle. This will become important later on. Now let's talk about the muscles. There are 7 extraocular muscles, but only 6 act to move
Levator
the eyeball
palpebris
itself.
superioris will be for
We'll be
elevation of the eyelid,
demonstrating how
upper
they fit
eyelid.
together from 2 different angles, from the front of the right eye and from above in cross-section. The 6 muscles include the 4 rectus muscles and the 2 obliques. The 4 rectus muscles all originate from the common tendinous ring at the back of the orbit, but insert onto the eyeball separately. They take their names from their insertions. The 4 muscles are the inferior rectus, which inserts inferiorly on the undersurface
That
of
is
the
inferior
eyeball.
rectus.
The medial rectus, which
Medial
inserts
rectus.
medially on the surface of the eyeball closest to the nose. The lateral rectus, which
Lateral
inserts
rectus.
laterally on the surface of the eyeball furthest from the nose. And the superior rectus, which inserts superiorly on the upper surface
So
of
these
the
are 4
eyeball.
recti.
The oblique muscles are more complex. They have different origins and insertions. We'll talk about the superior oblique first. It originates
That superior
just
rectus
next to
will
the
hook
tendinous
around
ring
the
and inserts
trochlea,
on the posterior
and then it
superior
will be going
surface of the eye.
posteriorly and laterally.
However, unlike the superior rectus, its path is not straight. From the surface of the eyeball, it runs anteriorly and medially toward the nose, passing through a fibrous pulley called the trochlea. It then continues posteriorly towards its origin at the back of the orbit. Because of the pulley, the muscle pulls its insertion point anteriorly and medially toward the trochlea, rather than posteriorly towards its origin. The inferior oblique, meanwhile, originates on the medial wall of the orbit below the trochlea and inserts on the posterolateral surface of the eye. Like superior oblique, it pulls its insertion point anteriorly and medially. As a side note, the 7th extraocular muscle to be aware of is the levator palpebrae superioris.
This is levator
This is the
palpebrae
muscle that
superioris.
works to elevate the eyelid. As it doesn't move the
Elevation
eye
of upper
itself,
eyelid.
we won't be talking about it too much in this video, but it does become relevant when we talk about cranial nerve palsies in video number 3. Let's go back to eye movements. Understanding which specific movements the rectus and oblique muscles are responsible for can be tricky, particularly as in the real world, eye movements involve all 6 muscles acting together. To help simplify things, think of the muscles acting in pairs. The medial and lateral rectus muscles work as a pair to adduct and abduct the eye.
This is abduction, adduction. Adduction by medial rectus, abduction by lateral rectus.
The lateral rectus abducts by pulling it away. The superior and inferior rectus muscles work
with elevation and depression.
And depress the eye.
That is superior rectus and inferior rectus.
Elevates by pulling it upward, while the inferior rectus depresses by pulling it down. They work best in abduction, where the eye is looking away from the nose. To understand why this is, we need to return to the anatomical structure of the orbit. From above, we can see that the anatomical axis of the rectus muscles is halfway between the sagittal plane, represented by the medial wall, and 45 degrees, represented by the lateral wall. It does not match up with the line of sight in the primary position of gaze. However, when the eye is abducted by about 22.5 degrees, the line of sight coincides with the anatomical axis of the superior and inferior.
So when eye is abducted 22 degrees, then it will be pure elevation, pure depression.
These muscles are therefore at their strongest when the eye is abducted rather than looking straight ahead. So that's the rectus muscles. But what about the obliques? The action of these muscles are more complex and can be the source of considerable confusion. In the next video, we'll be talking about the obliques and introducing a useful method devised by Dr. Paul Johns from St. George's Medical School to help you remember.
So, I end my lecture here. Thank you very much for taking out time. I know that your time is valuable and I appreciate you for spending some of the time with me. And this video lecture is mainly for educative purpose, and this shows you the different muscles and action of those muscles, terminology which is being utilized for the muscle action, and in one of the video it has been mentioned also regarding 3rd cranial nerve palsy, 4th cranial nerve palsy and 6th cranial nerve palsy. I'll be mentioning little bit regarding that. In a 3rd cranial nerve palsy, along with 4 muscles, that is medial rectus, superior rectus, inferior rectus and inferior oblique. Along with these 4 muscles, you have got a levator palpebrae superior is being paralyzed. So person will have ptosis along with movement of the extraocular muscle being affected, and also the fiber which is supplying to the circular fiber of the iris, the pupil will be dilated and fixed, not reacting to light. So if you come across dilated fixed pupil not reacting to light with ptosis and extraocular muscle involvement, medial rectus, superior rectus, inferior rectus and inferior oblique. When these 4 muscles are involved, now only superior oblique and lateral rectus is working. So lateral rectus will pull the eye in abduction and superior oblique will push the eye downwards. So the eye will be pointing downwards and outwards. So if that is the position with dilated pupil and ptosis, it is classical 3rd cranial nerve palsy. We call lower motor neuron 3rd cranial nerve palsy. While in a abduction or 6th cranial nerve palsy, it is supplying only one muscle, that is lateral rectus. Unopposed action of lateral rectus will make middle rectus to be more powerful, which will move the eyeball medially. So eye will be adducted. That eye will not be able to abduct, and hence the person will have a double vision, diplopia. To compensate that, the person will move the head so that the 2 eye can reduce the amount of diplopia. That is, if suppose the person has got right side lateral rectus palsy, so person will move the head towards the right side so that he can compensate for the movement of lateral rectus. and that will be peculiar in case of a 6th cranial nerve palsy. So you will have absence of movement, you will have strabismus or we call squint, plus you will have a diplopia, and to compensate that diplopia part, the person will turn the head towards the side of damage. While in case of a 4th cranial nerve palsy, the person will have absence of superior oblique action because 4th cranial nerve, trochlear nerve supplies superior oblique. That superior oblique will be paralyzed. So that is going to move eye downwards. So that action will be nullified and eyeball will be moving upward. So when you ask the person to look down and in, the eyeball will move up and in, and that will give rise to diplopia, and person will have eye in and up. That will be very peculiar in case of 4th cranial nerve palsy. And person, to compensate that, he will tilt the head in such a position so that the intorsion which is done by superior oblique is compensated by head tilting towards opposite side. This is all what you should know. I feel this lecture will be very helpful. So if you like the lecture, please don't forget to press button like, subscribe, and you can share with your friends.